I want to talk to you today about the smallest, cheapest, most familiar tablet in your medicine cabinet and about one of the biggest changes in medical advice of the last decade, a change that a great many people over 70 have simply never been told about: the daily aspirin. For decades, taking a low-dose aspirin every day was considered sensible, prudent, almost virtuous, something a person did to look after their heart, often on the advice of a doctor, sometimes on the advice of a friend or a magazine article, and frequently bought over the counter without any medical involvement at all. And then, in the last several years, the guidance changed substantially on the basis of large clinical trials, one of which specifically studied healthy older adults. The upshot, and I want to state it carefully, is that for many people who have never had a heart attack or stroke, particularly those over 70, the balance of benefit and risk from a daily aspirin is no longer considered favorable, and guidelines have moved away from routinely recommending it. And yet, enormous numbers of older adults are still taking one every morning out of habit because nobody has revisited it. So today, calmly and in balance, I'll explain what aspirin actually does, the single most important distinction in this entire topic, which is whether you're taking it to prevent a first event or a second one, what the evidence actually showed and why the advice changed, the bleeding risks that matter specifically after 70, the crucial rule about not stopping on your own if you're in the group who should continue, the interactions worth knowing, and the exact question to ask your doctor at your next appointment. And I'll say clearly at the outset, this video is not telling you to stop your aspirin, and it's not telling you to start one. It is telling you that this deserves a conversation you may never have had. Let me begin with the mechanism. Let me explain what aspirin actually does because it's rather elegant. Circulating in your blood are tiny cell fragments called platelets, whose job is to clump together and plug damage in blood vessel walls, forming the basis of a clot. That's essential. It's why you stop bleeding when you cut yourself. But in arteries that have developed atherosclerosis, the fatty plaque buildup I've described in other videos, a plaque can rupture, and when it does, platelets swarm to the site and form a clot that can block the artery entirely, and that is precisely how most heart attacks and many strokes happen. Aspirin works by irreversibly blocking an enzyme inside the platelet, permanently reducing that platelet's ability to clump for the whole of its remaining life, which is about 7 to 10 days. That's why a low dose taken daily is enough, and it's also why aspirin's effect lingers for several days after you stop taking it. So a daily low-dose aspirin makes your platelets permanently less sticky, which reduces the chance of a clot forming on a ruptured plaque, and that is the entire basis of its benefit. But you'll see immediately where the risk comes from, because platelets that don't clump as well also mean bleeding that doesn't stop as easily. And that is the trade-off at the heart of this whole discussion. So aspirin trades reduced clotting for increased bleeding, and everything depends on which of those two matters more for you specifically. Now, the distinction that decides everything. Here is the single most important distinction in this topic, and I want you to be able to say which group you're in. Secondary prevention means you already have established cardiovascular disease, meaning you have had a heart attack, a stroke or mini stroke, angina, a stent, a bypass, or diagnosed peripheral artery disease. For this group, the evidence remains strong and consistent. Aspirin reduces the risk of another event. The benefit clearly outweighs the bleeding risk for most people, and this is exactly the group who should be taking it and, crucially, who should not stop without medical advice. Primary prevention means you have never had any of those events, and you are taking aspirin in the hope of preventing a first one. This is the group where the advice has changed and where this video is most relevant. Now, why did it change? Because for years, the assumption was that aspirin's modest reduction in first heart attacks and strokes was worth the bleeding risk, and then large randomized trials tested that assumption directly. The most relevant to this audience studied healthy, older adults, most over 70, taking daily low-dose aspirin or a placebo for several years, and it found that aspirin did not prolong disability-free survival, produced no significant reduction in cardiovascular events in that population, and did produce a significantly higher rate of major bleeding, including bleeding in the gut and the brain. Other large trials in people with diabetes and in people at moderate risk found similar patterns, small reductions in cardiovascular events, offset by comparable increases in serious bleeding. And the reason age matters so much is that bleeding risk climbs steeply with age, so the same tablet that offers a small benefit offers a larger and larger risk as the years pass. So secondary prevention, keep taking it and don't stop alone. Primary prevention, particularly over 70, is exactly the situation guidelines have moved away from, and it deserves a conversation. Now, let me be precise about the risks. Let me be precise about the bleeding, because vague fear helps nobody. Aspirin increases bleeding in three main ways that matter. First, and most commonly, the gastrointestinal tract. Aspirin does two things to your gut. It makes platelets less able to plug damage, and it directly irritates the stomach lining by blocking the prostaglandins that protect it, so it both causes small erosions and makes them bleed more. The result is a meaningful increase in stomach ulcers and gastrointestinal bleeding, and this risk rises with age, with a previous history of ulcers or bleeding, with infection by the stomach bacterium Helicobacter pylori, with alcohol, and dramatically when aspirin is combined with anti-inflammatory painkillers, steroids, or anticoagulants. Importantly, this bleeding is often slow and invisible, producing not dramatic symptoms but gradual iron deficiency anemia, which shows up as fatigue, breathlessness, and pallor, which is exactly why unexplained anemia in an older person on aspirin needs investigating rather than just treating with iron. Second, bleeding in the brain, intracranial hemorrhage, which is far less common but far more serious, and which is the risk that weighs most heavily in the calculations for older adults because it can be catastrophic. Third, generally easier bruising, longer bleeding from cuts, and more nosebleeds, which are nuisances rather than dangers. Now, an important practical point: if you and your doctor decide you should continue aspirin and you have gut risk factors, adding a stomach-protecting medication, a proton pump inhibitor, substantially reduces the risk of ulcer bleeding, and that combination is genuinely worth asking about. So the main risks are gut bleeding, often slow and hidden, and the rarer but graver brain bleed, both rising with age, and a stomach protector can meaningfully reduce the first. Let me give you the warning signs of bleeding because everyone taking aspirin should know them. Contact your doctor urgently for black, tarry, sticky stools, which, as I've said across this channel, means digested blood from higher up the gut, for vomiting blood or material that looks like coffee grounds, for bright red blood in the stool, for severe or persistent abdominal pain, particularly burning pain in the upper abdomen, which may indicate an ulcer, and for unexplained fatigue, breathlessness, dizziness, or pallor, which can indicate slow blood loss and anemia. And seek emergency help immediately for a sudden severe headache, especially the worst headache of your life, for confusion, drowsiness, weakness, or numbness on one side, difficulty speaking, or vision loss, which are the signs of bleeding in the brain and also of a stroke, remembering fast, and importantly, for any significant head injury, because as with anticoagulants, a person whose platelets are impaired can bleed inside the skull after what seems like a minor bump, so a head knock deserves assessment rather than a wait and see. And a practical note: if you're on aspirin and you develop indigestion or upper abdominal burning, please don't simply treat it with over-the-counter remedies indefinitely, because that can mask an ulcer. Mention it to your doctor. So black stools, vomited blood, and abdominal pain are urgent neurological symptoms, and head injuries are emergencies, and new indigestion deserves reporting rather than self-treating. Now, let me talk about the rule that matters just as much in the other direction. Do not stop aspirin on your own if you're in the secondary prevention group. This deserves emphasis because the news coverage of the guideline changes has caused a genuine problem. People hearing that aspirin is no longer recommended and stopping their own without realizing that the change applies to primary prevention only. If you have had a heart attack, a stroke, a stent, or a bypass, your aspirin is doing important work. And studies have shown that stopping antiplatelet medication in people with established cardiovascular disease is associated with an increased risk of events in the following weeks, and there is a particular concern about stopping abruptly, with some evidence of a rebound effect. And there's a second situation where this is critical if you have a coronary stent, particularly a recent one. Stopping your antiplatelet medication can cause the stent to clot off, which is a catastrophic event. So that decision belongs entirely to your cardiologist. So the rule is simple. Secondary prevention aspirin is stopped only on medical advice, never because of something you read or heard, including this video. And for those in the primary prevention group who decide with their doctor that stopping is right, the good news is that it's generally straightforward. There's no complex taper required in the way there is with beta blockers, though your doctor may still prefer a specific approach depending on your circumstances. So never stop secondary prevention aspirin alone, and let stopping in the primary group be a decision made with your doctor rather than after a headline. Let me cover interactions and practical points. First, the most important combination to avoid aspirin plus the anti-inflammatory painkillers ibuprofen, naproxen, and diclofenac because both irritate the stomach and both affect clotting, and together they multiply the risk of serious gut bleeding. So paracetamol is generally the safer everyday painkiller for someone taking aspirin, and regular anti-inflammatory use should be discussed with your doctor. There's also a subtlety worth knowing. Ibuprofen can interfere with aspirin's antiplatelet effect if taken shortly before it, so timing matters, which is another reason to ask rather than assume. Second, aspirin combined with anticoagulants like warfarin or apixaban substantially increases bleeding risk, and while there are specific situations where doctors deliberately prescribe both, it should never happen by accident, so if you find yourself taking both, confirm it's intended. Third, alcohol, which increases stomach irritation and bleeding risk. Fourth, certain supplements affect clotting, high-dose fish oil, ginkgo, and others worth checking with a pharmacist. Fifth, aspirin can worsen asthma in a minority of people, and it interacts with several other medications, including some blood pressure drugs and methotrexate. Sixth, if you have gout, know that aspirin at low doses can raise uric acid. And seventh, a practical one. If you're having surgery or dental extraction, tell the team because whether to pause aspirin depends entirely on why you're taking it and what procedure you're having, and that is their decision to make, not yours. So the big one is avoiding anti-inflammatory painkillers, along with checking any anticoagulant overlap, moderating alcohol, asking about supplements, and telling every surgeon and dentist. Let me give you the exact conversation to have with your doctor because this is the practical purpose of the whole video. At your next appointment, ask these questions. First, and most important, am I taking aspirin for primary or secondary prevention? In other words, have I had a cardiovascular event, or is this to prevent a first one? Second, if it's primary prevention given my age and my current risk factors, is the balance of benefit and bleeding risk still in my favor, or should we consider stopping? Third, what is my bleeding risk? Do I have a history of ulcers, stomach problems, or anemia? And if I'm continuing, should I be on a stomach protecting tablet? Fourth, is there anything else on my medication list that increases my bleeding risk, especially painkillers or anticoagulants? Fifth, if I'm stopping aspirin, what should I be doing instead to protect my heart? Which brings me to the most important point of all. Because here's what I want to leave you with about the wider picture. If you were taking a daily aspirin in the belief that it was your heart protection, then stopping it should prompt you to double down on the things that actually make the biggest difference. And those are the unglamorous ones this channel talks about constantly: controlling your blood pressure, which is one of the most powerful interventions in all of medicine, managing cholesterol appropriately, including statins, if indicated, since the evidence for those in primary prevention is considerably stronger than for aspirin, not smoking, staying physically active, managing diabetes, and keeping your weight sensible. Aspirin was never the foundation of heart protection, and for many people over 70, it turns out not even to be a useful addition. So the energy is far better spent on the measures that genuinely work. So ask the primary or secondary question, ask about your bleeding risk and stomach protection, and redirect your attention to blood pressure, cholesterol, smoking, and activity. Let me paint you two pictures. First, picture a woman of 78 who has taken a low-dose aspirin every morning for 22 years because a doctor suggested it in the 1990s and nobody has mentioned it since. She has never had a heart attack or a stroke. Over the past year, she has become gradually more tired and breathless on stairs, which she has attributed to age, and a blood test finally shows iron deficiency anemia, and the investigation that follows finds a slowly bleeding stomach erosion. She had been quietly losing blood for months from a tablet that, according to current evidence, was providing her with essentially no benefit at her age and risk level. That is not a rare story, it is a common one, and it is entirely preventable by one review conversation. Second, picture a man of 71 who had a heart attack 4 years ago and a stent placed, who reads a newspaper headline saying doctors no longer recommend daily aspirin, and who, reasonably enough, stops his. He is in exactly the group for whom the medication remains clearly beneficial and for whom stopping carries real risk, particularly with a stent in place, and the headline he read was about a completely different situation from his own. Two people, two opposite errors, and both would have been solved by the same thing, knowing which group they were in and asking a doctor rather than assuming. And let me speak briefly to those caring for an older parent or partner. Find out whether they take a daily aspirin at all, because many people take one bought over the counter that appears on no medical record whatsoever, and that gap matters enormously when other medications are prescribed. Find out why they take it, and if the answer is a vague "nobody remembers" or "a doctor said so years ago," that is precisely the situation this video is about, and it deserves a review. Watch for the quiet signs of slow bleeding, increasing fatigue, breathlessness, and pallor, which are so easily attributed to age, and make sure any unexplained anemia gets investigated rather than just treated. Guard against the dangerous combinations, particularly ibuprofen bought at a supermarket for aching joints, and carry the emergency rules, especially the head injury one, because a bumped head in an older person on aspirin deserves a check even when they insist they're fine. Let me draw this all together, calmly. Aspirin permanently reduces the stickiness of platelets, which lowers the chance of a clot forming on a ruptured plaque, and that same action increases bleeding, so the entire question is which of those two matters more for you. If you have established cardiovascular disease, a heart attack, stroke, stent, bypass, or peripheral artery disease, the benefit remains clear. Aspirin is doing real work, and stopping it should only ever happen on medical advice, particularly with a stent. If you have never had such an event, and especially if you are over 70, you are in the group where the large trials found no meaningful benefit and a clear increase in serious bleeding, which is why guidelines moved away from routine recommendation, and where a review conversation is genuinely overdue for a great many people. The risks that matter are gut bleeding, often slow, hidden, and presenting as unexplained anemia, and the rarer but graver bleed in the brain, both of which climb with age, and both of which are magnified by anti-inflammatory painkillers, anticoagulants, and alcohol. So here's what I'll leave you with, straight and clear. First, find out which group you're in, because that single fact determines everything. And if you don't know, that's your question for your next appointment. Second, if you have had a heart attack, stroke, or stent, keep taking it and never stop because of a headline, including this one. Third, if you're taking it purely in hope without any cardiovascular event behind you, and particularly if you're over 70 or bought it yourself, book the review because that conversation is long overdue and may well end with you safely taking one fewer tablet. Fourth, protect yourself while you take it. No ibuprofen-type painkillers without asking. Ask about a stomach protector if you have gut risk factors, moderate the alcohol, tell every dentist and surgeon, and never ignore black stools, unexplained tiredness, or a bumped head. And fifth, remember what actually protects your heart, because if this video persuades you to stop an aspirin that wasn't helping, the worst outcome would be feeling less protected. And the right response is to put that energy into your blood pressure, your cholesterol, your activity, and if you smoke, into stopping, all of which do far more than a small white tablet ever did. Medicine changes its mind when the evidence changes, and that is a sign of a discipline working properly rather than a reason for cynicism, but the change only helps you if somebody tells you about it, which is what this video has tried to do. So take care of yourself, find out which group you're in, and take that question to your doctor rather than to your own conclusions. And because starting, continuing, and stopping this tablet all depend on your individual history and risk, please treat this as your reason to have a proper review with your own physician. Treat black stools, vomited blood, or unexplained tiredness as an urgent call, and treat sudden severe headache, one-sided weakness, speech difficulty, or any head injury as your reason to seek emergency help immediately.